With this, we move on to the third session of today's scientific feast, and the topic is Beyond Statins, Treating and Evaluating Residual Atherosclerotic Cardiovascular Risk. To speak on this particular topic, I would like to invite speaker Dr. Shilanjan Ray, who is the Assistant Professor of Cardiology at KPC Medical College, Kolkata, Consultant Interventional Cardiologist at Charnock Hospital and Manipal Hospital. He has special interest in cardiodiabetes, coronary intervention, and heart failure therapeutics. He is author of multiple book chapters and also published in several peer-reviewed journals. I welcome you, sir. To chair this particular session, I would like to invite Dr. B.P. Pandey, a very senior interventional cardiologist and secretary of Howrah Town Diabetes Study Society. I would request our chairperson, sir, to introduce our speaker.
Slide changer. Oh, দাঁড়াও এইভাবে এটা বড় করো, বিগ স্ক্রিন করো, এই যে দিস ওয়ান বিয়ন্ড স্ট্যাটিন। Good.
Dear friends, we are looking at this people targets in day-to-day practice, LDL and other non-HDL cholesterol. And statins are not totally clear. So we hear from Dr. Shilanjan Ray what else means.
Thank you very much, sir, and very good morning to all the dignitaries who are present here, and a special mention of thanks to Howrah Diabetic Study Society for inviting me in today's discussion. So my topic is Beyond Statin, Treating the Residual Atherosclerotic Cardiovascular Risk. So what do you mean by residual cardiovascular risk? It means that the risk of microvascular events, including the risk from the established or the traditional risk factors. By traditional risk factors, we mean hypertension, diabetes, obesity, and the non-traditional risk factors or the emerging risk factors that persist in the patient, the risk of the cardiovascular diseases that persist in spite of the current evidence-based medical care. So in spite of giving all the best standard of care or medications, the amount of risk that the patient still experiences of development of a future atherosclerotic cardiovascular disease or an acute cardiovascular event is being defined as this residual vascular risk or cardiovascular risk. We know that while HDL-C lowering with the statins, it reduces the cardiovascular risk, a substantial amount of residual risk it remains. Statin, we know, is the main pillar or the foundation of reducing the residual cardiovascular risk in a patient having atherosclerotic cardiovascular disease or a part of primary prevention. But large meta-analysis, they have showed that in spite of statin therapy, there lies a 78% risk of a major vascular event that remains unaddressed in spite of statin therapy. High dose of statin only further lowers the risk of CV events by merely 0.8 to 1%. You can see that aggressive LDL lowering even with maximum dose of statin, namely 80 milligram atorvastatin, reduces the absolute cardiovascular risk by only 2.2 compared to atorvastatin 10, which was found in the TNT trials, the large landmark trials. So incremental increase in the dose of statin, though it reduces the risk of ASCVD events, it is not the answer to the entire or the cumulative atherosclerotic cardiovascular risk that the patient is experiencing. And there are multiple other factors that needs to be addressed to reduce this residual cardiovascular risk. So what is the concept of this residual risk? You can, it can be understood from this elegant illustration that patients who is having a known cardiovascular disease, this patient can either have a part of residual risk because of high LDL cholesterol or the total cholesterol, and some amount of risk due to increased in the inflammatory markers, namely the CRP, which is a marker of this, inflammatory risk. Now you can see if the patient, suppose baseline, patient is having a high LDL cholesterol level of 150 and a high hsCRP of 4.5. Initial treatment will be with high intensity statin therapy, and after high intensity statin therapy, there can be three pathways or how the patient can go. One can be that there can be reduction in the LDL cholesterol level. That is, you can see in this part that his LDL cholesterol reduces to 1.4, but the HSCRP remains elevated. So there is a residual inflammatory risk that persists in spite of LDL cholesterol lowering. In these subsets of the patient, possibly anti-inflammatory therapy is the answer to reduce his excess or the residual risk. In a small subsets of the patient, in spite of high intensity statin therapy, you can see the HSCRP has come down, so the inflammatory risk has come down. But high intensity statin is unable to lower the LDL cholesterol to significant level. The baseline was 150, it has only come down to maybe 120. So these patients have a residual LDL cholesterol risk due to high LDL levels. So this patient will require further LDL reducing therapies in the forms of ezetimibe or bempedoic acid or injectable therapies like PCSK9 inhibitors to reduce this further LDL cholesterol risk. And in another patient, there can be residual risk from other components. You can see in this patient, the LDL cholesterol has been lowered down, the HSCRP has lowered down, but this patient is having a high levels of lipoprotein A, which is also a novel marker of this residual risk, and also the triglyceride level is high. So these patients will possibly requiring additional therapies to reduce the atherosclerotic risk in these patients by reducing the triglyceride and by reducing target-directed therapy to reduce the lipoprotein A levels. So this is the basic concept of residual risk reduction. That is, high-intensity statin will form the basic, the foundation of risk reduction. If the patient is showing adequate LDL risk reduction, then we have to look for the inflammatory markers like CRP. If the CRP level is very high, we might have to consider anti-inflammatory therapies. And if the LDL levels and the inflammatory markers both are within the normal levels, we have to look at the non-LDL cholesterol levels like the non-HDL-C or the triglyceride level or the novel risk markers like lipoprotein A. And we might have to use specific pharmacological agents to reduce these other residual risk markers like triglycerides or non-HDL cholesterol or lipoproteins to further reduce the risk of ASCVD. This diagram also illustrates the various pathways through which the residual risk can be addressed. We have already discussed, so these are the patients who are at high risk of ASCVD. Despite current evidence-based management, the residual risk of ASCVD persists. So what can be done to reduce the residual cholesterol risk? We all know that on top of statin therapy, we have got multiple medicines in our pursual at present. We have got ezetimibe for further LDL lowering. We have got Bempedoic acid, which is a novel ATP citrate lyase inhibitor that reduces the reduces the LDL cholesterol level. And we also have got the injectable therapies in the forms of PCSK9 or the other molecular therapies like the siRNA or Inclisiran that can reduce the LDL cholesterol to a significantly lower level, up to the tune of maybe 80 to 85% when used in combination therapies. And improve it, Fourier, Odyssey trials, they support this, reduction of LDL cholesterol or reducing the LDL residual cholesterol risk. But even after treating this LDL cholesterol, multiple pathways remains that needs to be addressed to target this residual risk. One, we have already discussed the residual inflammatory risk or inflammatory reduction target, which can be done by novel anti-inflammatory agents, which has been tried in various studies like the CANTOS trial, where newer MAB like cananicumab was tested, the Colcott trial and the Lodoco with low-dose colchicine acting as an anti-inflammatory agent which can reduce the vascular inflammation and can reduce the risk of development of future major adverse cardiovascular events, MI and stroke, which has shown very encouraging results, and other anti-inflammatory therapies like methotrexate, which has also been tried. Residual thrombotic risk is another pathway which poses a patient of ASCVD or established ASCVD at risk of development of future cardiovascular events. So in spite of lowering LDL, in spite of addressing the inflammatory risk, some patients who are at higher risk of thrombosis, these patients may not, their risk may not be completely abolished with the use of single antiplatelet agent. And we have to use dual antiplatelet agents for a longer duration of time, or using dual pathway inhibition in the form of a single antiplatelet agent and low dose anticoagulant therapy, like which was tried in the COMPASS trial, where along with aspirin therapy, low dose rivaroxaban 2.5 milligram twice daily was used to further reduce the risk of to reduce this thrombotic risk, particularly in the patients who are at high ischemic or thrombotic risk. So Pegasus TIMI 54 was a trial which tried low dose of ticagrelor 60 milligram BD along with aspirin even after 1 year post ACS or post stenting, and Compass trial which tested this hypothesis of dual pathway inhibition using one antiplatelet and one anticoagulant, low dose rivaroxaban, vascular dose of rivaroxaban, to address this residual thrombotic risk, which also showed a very encouraging results and reducing the total cardiovascular mortality of up to 17%, which was seen in the Compass trial. Residual triglyceride risk is another arm to address this unmet, residual risk. We know that in spite of reducing the LDL cholesterol, the triglyceride containing lipoproteins, the TGLs or the remnant lipoproteins or the non-HDL cholesterol, which is an indirect marker of ApoB level in the blood or a marker of the atherogenic LDL particles in the blood, also indicates, it's also a risk factor for the development of atherosclerosis. And for reducing these residual triglycerides or excess triglycerides, which is a common problem in Indian scenario, particularly Indian diabetic, where atherogenic dyslipidemia is extremely prevalent, even with a low LDL cholesterol or normal LDL in the target level, these patients are at a much higher risk of development of ASCVD. And to reduce this excess triglyceride or triglyceride-rich lipoprotein-mediated risk, we have to reduce the triglyceride, and we have got various molecules in our hand, though the initial molecules like fenofibrate didn't show significant improvement in terms of reduction in the ASCVD outcomes. But the recent molecule like icosapentaethyl, which was tried in REDUCE-IT trial, it showed when added on top of statin therapy or other LDL lowering therapies, particularly in the patients who have already experienced an atherosclerotic cardiovascular events, adding icosapentaethyl 2 gram per day possibly will further reduce the risk of development of future atherosclerotic cardiovascular event. Another newer molecule prominent with pemafibrate, that is a novel fibrate molecule, also was tried in the prominent trial in the patients of ASCV, though it failed to met the primary endpoints, but it showed a indication towards improved outcome in these patients. So triglyceride is another part, or the triglyceride rich lipoproteins, that needs to be addressed in certain subsets of the patient, particularly in obese patient, diabetic patients, patients of metabolic syndrome, patients in whom the LDL levels are, baseline LDLs are low with a high triglyceride and low HDL, that is an atherogenic dyslipidemia pattern, where these triglyceride has to be addressed. Residual lipoprotein risk, this is a novel concept that is arising nowadays to address the residual lipid risk in this patient. That is, patient who have already achieved the target LDL cholesterol level after having an atherosclerotic cardiovascular event. Suppose a patient who has suffered an MI, we are giving this patient high intensity statin Bempedoic ezetimibe. We have achieved an LDL cholesterol below 50, maybe below 40, we are happy with it. Non-HDL cholesterol level is below 70, we are happy with it. But still this patient is experiencing recurrent vascular event. So a significant amount of residual risk is possibly remaining in this patient, and majority, a significant proportion of this patient, when tested for LPA levels or the lipoprotein A levels, they have shown very high lipoprotein A levels in spite of normal levels, normal target levels of LDL and normal target levels of non-HDL cholesterol. So LPA per se is an independent and novel risk marker or risk factor for development of coronary atherosclerosis. And it should be one of the, lipid parameters in the extended lipid regime that should be tested in a patient, particularly in the high-risk patient or patients who are experiencing recurrent cardiovascular events, because with the novel molecular biologic therapies, now LPA can even be, targeted in these patients where high LPA level is possibly the culprit for accelerated atherosclerosis or for the patients experiencing recurrent atherosclerotic cardiovascular events. So in these patients of high LPA levels, we have got newer LPA agents which target specifically the lipoprotein A synthesis in the body, and we'll be knowing the names of the molecule. and residual diabetic risk or residual metabolic risk. Definitely it is one of the major risk factors that needs to be addressed irrespective of the patient status or whether it's a case of primary or secondary prevention. Any diabetic patient, obese patient, adequate glycemic control, body weight control, blood sugar control, these are mandatory, and preferably the important crux of the story is that it is not about glycemic control by any means. It is by glycemic control by using the agents which have shown benefits in terms of reduction in heart failure and atherosclerotic cardiovascular disease. So in the patients who are having high risk of ASCVD or high ASCVD risk factors or established ASCVD, anti-diabetic therapy or control of blood sugar should be done with the use of SGLT2 inhibitor or GLP-1 receptor agonist. So obesity control and diabetes control should be preferred agents will be SGLT2 inhibitor and GLP-1 to further reduce the risk of atherosclerotic cardiovascular events, as has been seen and established by the multiple myriads of large RCTs of SGLT2 inhibitors as well as GLP-1. So this is the entire spectrum of residual risk, the pathways of residual risk and how these residual risk pathways need to be addressed. So in a nutshell, that you have to know as a physician. So these are the molecular pathobiological mechanisms in details that can be addressed, as we have already discussed in terms of lipoprotein. Now with the use of novel targeted therapies, we can address separately triglyceride, lipoprotein A, ApoA1, all these things, remnants lipoproteins. In terms of inflammation, we can address HSCRP using high intensity statin. We all know rosuvastatin has got significant HSCRP lowering effect. Bempedoic acid has shown a significant effect on anti-inflammatory effect, independent of its LDL lowering effect, and also the novel therapies that we have already discussed. The LPPLA2, ICAM, VCAM, the adhesion molecules which all promotes inflammation can be targeted separately. Primarily, low-dose colchicine, as I have already told, shows a very promising results in this pathway. These are modifiable risk factors. Historically, we control all these traditional risk factors. Metabolic risk of insulin resistance, MASLD, hyperuricemia, microalbuminuria, all has to be addressed simultaneously using SGLT2 inhibitor, GLP-1 if the patient is having diabetic kidney disease, maybe finerenone will be the answer to that problem. And also thrombotic risk, addressing thrombotic risk with antiplatelet agents and dual pathway inhibition with low-dose anticoagulant can further reduce this residual risk. So you can see these are the pathways of residual risk. One by one we have to look into that how can we further reduce the risk of residual disease. So only targeting LDL cholesterol is not the answer. After LDL cholesterol, we have to look for the HDL cholesterol levels. After we have achieved the HDL cholesterol level, in spite of that the patient is experiencing recurrent atherosclerotic cardiovascular events or at risk of recurrent vascular event, we have to look for the novel risk markers like the lipoprotein A. We have got the newer molecules which in addition to LDL levels also further lowers the lipoprotein A, and in very near future targeted lipoprotein A directed therapies are in the horizon that is going to come up. Residual inflammatory risk with these anti-inflammatory agents, residual thrombotic risk, though there is no simple biomarkers, but for the high risk patient having vascular disease in multiple vascular territories or polyvascular disease involving coronaries, peripheral, cerebral, so patient having CAD and PAD together, in these high risk patient we might consider using a single antiplatelet with a load of vascular dose of rivaroxaban 2.5 milligram twice daily for further reducing the residual thrombotic risk. Residual triglyceride risk we have already discussed. Now we have got in our disposal icosapentaethyl or pemafibrate, maybe it's being tried in other strategies. So these are the molecules that has been tried for reducing the inflammation. Cananicumab in CANTOS trial, the lipoprotein associated phospholipase A2, darapladib. However, the initial results has been disappointing. Methotrexate and colchicine. Particularly important is colchicine, where the COLCOT trial showed a 23% risk reduction in MACE. After MI, LODOCO trial with a low-dose colchicine administration to the stable CAD patients resulted in 30% reduction in the CV events compared to placebo. All these studies indicates that over and above this LDL lowering of the triglyceride, there remains a smoldering inflammatory activity in the vessel wall, which in a large number of cases is the primary factor of this plaque disruption and acute cardiovascular events that can be corrected or counteracted with these anti-inflammatory therapies. These are triglyceride-based therapies. We have already discussed it. Now, let us have a brief look about the novel molecules that are in the horizon for the treatment of other lipoprotein, moieties. Inclisiran, we all know, is a silencing RNA, bempedoic acid, pemafibrate, known to us. But the newer therapies are anti-ApoC3 antisense oligonucleotide volanesorsen, which primarily acts in the lipoprotein lipase pathway, reduces the triglyceride. Evinacumab is a monoclonal antibody targeting the angiopoietin-like 3, primarily lipoprotein lipase mediated action. Irrespective of the LDL levels, it reduces triglyceride, LDL and HDL cholesterol. Vupanorsen, another angiopoietin-like 3 ASO targeting agent, reducing the triglyceride level. These are all the lipoprotein, specific lipoprotein A reducing agents. You can see the Ionis APO and the Olpasiran, which are the silencing RNA inhibiting specifically the lipoprotein A levels. So these are the molecular targeted directed therapy, the newer therapies that are in the horizon for the treatment of these non-LDL-C, residual risk factors. So finally, my concluding slide is that how to answer the residual risk. The source of this residual risk has to be kept in mind that it is multifactorial. It is neither only lipid or neither only inflammation or metabolic factor. It's a conglomeration of the lipid and the non-lipid factors like smoking, obesity, diabetes, elevated triglyceride, low HDL cholesterol, and the high density lipoprotein cholesterol, presence of ApoB, high LPA levels, also the LDL particle numbers. Epidemiological, clinical, genetic studies, including the Mendelian randomization, support the independent role of elevated triglyceride in the atherosclerotic cardiovascular events. And can the residual risk be mitigated, eliminated? Significant progress has been made in reducing the traditional risk factors. These emerging risk factors like LPA, inflammation, genetic factors, psychosocial factors, they continue to contribute to the residual risk. However, with the newer experimentation, newer directed molecular therapies, we gain more knowledge in addressing these novel pathways of residual atherosclerotic cardiovascular risk, and possibly by the comprehensive approach in very near future, we can reduce these residual risk of atherosclerotic cardiovascular events to a large extent by addressing all these pathobiological mechanisms. Thank you very much for your patient listening.
Thank you, Dr. Shilanjan Ray, for nicely explaining risk factor other than LDL cholesterol, and they are having big role in residual risk. My question is that atheromatous process is lifelong process, and in secondary prevention, when already atherosclerosis, there is events we start, then how much residual risk reduction we can expect. So should we target LDL cholesterol, low LDL cholesterol from second or third decade in high risk individuals? Because lifelong, if we can keep LDL cholesterol low, then cardiovascular event will occur at a later date. Because the LDL cholesterol and years of control of LDL cholesterol, that will decide the risk of CVD.
Absolutely. I totally agree with your comment, sir, that it is the cumulative exposure to LDL cholesterol or the cholesterol years that counts. The total cholesterol, it's not only about the absolute value of cholesterol, but the years that the patient is harboring this high LDL cholesterol value. So naturally, screening for lipid disorders, so screening for high LDL cholesterol or any forms of dyslipidemia, it should begin at a very young age, at least by the second decade of life, maybe while the patient is going out of school or in the college level, a basic LDL lipid assessment should be done. In the patient who are at high risk or showing signs of familial hypercholesterolemia, the testing should be done even at a higher, earlier age group, in the pediatric age group, if there is a high index of suspicion by the pediatrician. And if the patient is found to have very high levels of LDL cholesterol, which might corroborate with the possibility of a heterozygous hypercholesterolemia, which is not very uncommon in our population, that is a patient having a baseline LDL cholesterol of 180, 190, 200. These patients, if diagnosed maybe at the age of 18, 20, and we can initiate lipid lowering therapy at a younger age, even with a low intensity statin therapy, if taken for a longer period of time, we definitely can reduce the risk of development of future ASCVD to a large extent. So I am not very confident about starting anti-lipid therapy in a wide percentage of the population, but a screening program for lipid disorders or basic extended lipid profile testing should be one of the part of our health programs, government health programs, to pick up this high-risk patient.
Are you using colchicine in post-MI patient?
Colchicine, I
if
haven't
yes,
yet.
how long?
It's not yet available at the specific preparation of low-dose colchicine.
Yeah, it's available.
I think
Colchicine 0.5 is available.
0.5 is available.
It has
yes.
got a class 2A recommendation in both CCS as well as post-MI.
Post-MI. I
For
haven't yet
post-MI.
started. I
Have
have
you
got
used
to.
it?
Yeah,
Have you used it?
yeah. I use it only if you have a HSCRP
HSCRP is
between
high.
2 and 6.
2 and 6. Yes.
If it is more than 10, look for infection. If it is beyond 2 and below 6, we use it. What between 6 and 10, I don't know. Probably they need more
And how
work.
long?
It has to be continuous. Just like statin, it needs to be continued. Only word of caution, it has got two-way because non-cardiovascular mortality is increased. What is the reason? So two things which are high. One is pneumonia that was shown in the Calcutta trial. And second is the non-cardiovascular deaths are more in colchicine. That's why it's not getting one. So some people are dying either from malignancy or pneumonia, we don't know, but
Neutropenic sepsis
non-cardiovascular
is also
deaths are
slightly
more
higher.
with colchicine.
And of course, that will come to market in 2027 or 8. Inclisiran and pelacarsen.
Yes.
Early reports, what they suggest that reducing LPA reduces CV mortality.
Yes. The initial results with olpasiran and pelacarsen is showing that targeting LPA in the high risk patient having LPA more than 100 maybe, it's showing a trend towards better cardiovascular mortality.
Shilanjan, what's your concept of bempedoic acid in triglyceride level? Does it increase? Does it decrease? Or it remains
Bempedoic
neutral?
acid decreases triglyceride level. It quite
Because
significantly decreases.
We are seeing few cases where triglyceride is going up.
But as far as literature suggests, bempedoic acid can reduce triglyceride in the tune of 20%. Up
But
to 20
there
to
is
20.
also report of increase. So
Increase.
that's one thing. And in young reproductive age group, young females, non-statin therapies for
Yes.
mixed dyslipidemia, what do you suggest?
Options are very limited. Options are bile acid sequestrants, which can be used.
Which you don't have
We
experience.
don't have experience.
Fibrates.
Technically, fibrates can be used. Mipomersen is one agent that can be used in pregnancy. We have not got, first-hand experiences. So our options are very limited.
And what about EPA for pure hypertriglyceridemia?
EPA, I can't remember whether in it has been tried in pregnant patient or not. I think pregnant patients were not
no
included.
idea.
They were
I
primarily
also do not have
post-MI
any
patients.
idea.
Fibrate does not reduce mortality. And ecosap antiethyl could reduce mortality by almost 20%.
But
On top
still,
of
if you look
statin.
at the sale of fenofibrate in India, it's remarkable.
No, cell is not a criteria.
No, the reason is because all these trials were very small, limited period of time. I am also using for 30 years. Triglyceride reduction is important, but the trials are not showing. Neither femafibrate trial nor a field trial, none of the trial could show. The explanation they give that while you are reducing triglyceride, you are not reducing the intermediate density and a small density LDL. So we need a drug which acts on the lipoprotein lipase pathway so that when you reduce triglyceride, you have to reduce IDL and small dense LDL.
Dense LDL.
So those molecules like angiopoietin, like 3 inhibitors, which do not cause diabetes, probably is the future. So we need to reduce it, but how to reduce it, we don't know, because a reduce it trial was also controversial. You have more deaths in a placebo arm, and that's why it was shown to be super beneficial. So that story is still unmet. So we thank Shilanjan for the beautiful presentation. Thank you.
Thank you, sir. I would like to request you to felicitate Dr. Shilanjan Ray. Sir, kindly stay back. Dr. Shilanjan Ray, please kindly join us for the felicitation. Thank you, Chairperson. Thank you, Speaker, sir, for the insightful presentation.